Hello and welcome to the very first episode of the pIBD Digest. I'm your host, Dr. Tracy Coelho.
And I'm your co-host, Dr. Chris Bakewell. Thanks so much for joining us. I think we should probably start by doing some introductions. So, Dr. Coelho is a consultant paediatric gastroenterologist in sunny Southampton.
And Dr. Bakewell is a senior pediatric gastroenterology resident doctor. I think the terminology has changed now, and soon to be a consultant. Chris has only just moved from sunny Southampton to rainy London, and he's already building his ark to survive the stormy weather at King's College Hospital, London. So Chris, your final 6 months, not sure what happens next. We sincerely hope that your sensible GPS will bring you back to sunny and vibrant Southampton.
You never know what will happen to you, but I am very pleased to be keeping my hand in gastroenterology through this podcast.
It would be my pleasure to keep you rooted to Southampton. Like yourself, I'm overly delighted and thrilled about the podcast, especially the first one. Now, this is an educational series on pediatric onset inflammatory bowel disease that we all as health professionals like to call pIBD. Now, I hope our listeners will like the name of the podcast, pIBD Digest. What do you think?
I think so. It certainly took a while to come up with.
Yeah. So, digestion is the theme in gastroenterology, so therefore the pIBD Digest. And we hope our educational series will not give our listeners indigestion. Am I saying it correctly?
Yeah, sounds good.
Yes. And we'll try our best, but we cannot promise the same for our bad jokes, or rather Chris's bad jokes.
Sorry.
So, Chris, it's been quite some time that I and you have been talking about doing this podcast on pIBD, working out the practicalities. And here we are with the first episode of the series.
Certainly it's been what I would call a labour of love putting it together. Certainly a lot of work on your part, Dr. Coelho. It does feel a bit surreal to finally be recording it. I guess, as you say, for our listeners, we should explain the whole reason for the Paediatric IBD Digest in the first place is essentially sharing knowledge about lots of different aspects of paediatric IBD. Principally, I'd say it is for health professionals, but it's also for our patients and for their families who maybe just want to learn a little bit more about their condition.
Yes, indeed. So, Chris, this is our very first podcast, as you know. So how do you feel about embarking on this educational journey of pediatric IBDology as a co-host? Are you excited, nervous? If you are, I can assure you, I have learned how to edit the ums and ers. Although it applies more for me rather than you. You're a smooth talker, aren't you?
Well, I shall start by not saying and say I'm hugely excited. Genuinely, I think a subject like Peds IBD is probably the perfect topic for this sort of platform. And I guess what I mean by that is there's loads of debate about the best clinical practice in IBD, but especially in pediatrics. And it's a field where there's, clinical experience counts for a huge amount. I think we are bound to have some good discussions, hopefully no arguments, but let's see. I'm certain that a few arguments will drive up our listener figures.
I agree. Hopefully no arguments, and even if there are, I know you will let me win. You're very kind and obliging. Now at this point, I would like to mention that our podcast will have an added feature at the concluding part of each episode. Do you know what I'm talking about? You know, don't you?
I think I know. I hope I know.
It's a couple of poetic verses at the end.
Yes.
Do you think our listeners will like it?
Yeah, I'm sure they'll find your poetry very interesting as long as you keep it to a medical topic.
I will try my best. Anyway, Chris, I think before rolling into the nuts and bolts of pIBD, for our listeners, because we may have an audience that is not medical, could you kindly describe what is inflammatory bowel disease?
I'll certainly give it a go. I think the answer to that question probably varies depending on your perspective. So now you can edit out. Ultimately, there's no perfect definition. I think because it's not a perfectly defined condition as things stand. If you look at it at its very basic level, as we know, IBD is a group of chronic disorders. They arise from inflammation within the GI tract. And broadly speaking, you can divide it into two groups, Crohn's disease and ulcerative colitis. But of course, there's a third group which fails to meet exact criteria for either Crohn's or UC and falls somewhere in between. Variably, we can call that IBDU or IBD undefined. How valid or even helpful those groups are in defining IBD in 2025 is certainly up for debate, and our guests will probably have an opinion on it. But I think it still is a helpful way to group them. And then going a bit deeper on a biochemical level, you'd say IBD is a disorder of the immune system, so the body's natural defenses. It arises from inappropriate activity or overactivity of immune cells, principally T lymphocytes, which then drive this process of progressive inflammation and damage within the lining of the wall and the GI tract. As things stand, we're not completely sure why it occurs for some children and not for others, although obviously there's a lot of research going on to answer that specific question. But it's certainly multifactorial with inputs from the genome, i.e. your genetic makeup, the exposome, that is to say your lifestyle and the exposures that you encounter over the course of your years. That includes certain elements of the diet as well. And then the microbiome, which is hugely of interest in lots of medical fields outside of IBD as well. And all of those factors probably require some initial trigger moment to kick off that cascade of inflammation, which then continues on unless treated. And that can be something seemingly as innocuous as a mild viral illness.
That's perfect. I think, Chris, you have been trained to perfection in sunny Southampton. Would you agree with me on this?
Certainly. And I would just like to add that no AI was used for that definition.
Absolutely, yes. Chris, one more question. Why do you think a podcast like this one, the pIBD Digest, how would it be useful?
From a selfish perspective, as a gastro trainee, I think it's going to be a really excellent resource. You're going to learn some of those finer points of IBD management in children, which aren't necessarily in textbooks. And I'm personally not someone that finds it too easy to sit down after a day of work and read a systematic review or papers otherwise. So I'm going to find it a lot easier to put on a podcast than sit and watch a video or read an article. And in that way, I think it will genuinely be very accessible to our audience. And I'm also hopeful that we'll learn a bit more about our guests on a personal level. All these people have a huge interest and wealth of knowledge in pediatric IBD, and they themselves are very interesting people with unique perspectives on managing this condition for, sometimes a lifetime.
Moving on, I must say that I am truly delighted to invite our very first guest on this podcast series, Dr. James Ashton. Dr. Ashton is Associate Professor of Paediatric Gastroenterology and a consultant in Paediatric Gastroenterology, Southampton Children's Hospital. He's got many hats, genomics and various other things. I'll let him talk about that. But James, a very, very warm welcome to you.
What an honor. Thank you so much for having me.
Thank you. So James, if it were up to me, as you're the first guest, I would give you a Maharaja's welcome, and that would involve a drum roll, fanfare, elephant parade, shower of petals. But sadly, because of budget cuts, because I and Chris have started with a budget of exactly zero, we have to do a very modest welcome of just words. Hope that's all right.
I think we'll get by it.
Thank you. So, James, how shall I describe you?
We have to keep it clean.
I will keep it clean. I will try my best. James, you are the young czar of pediatric IBDology. Or shall I say that, James, you are pure gold or the crown jewel for the Department of Paediatric Gastroenterology in Southampton. Chris, would you agree with that?
I was going to give him a Maharaja's welcome, but he's definitely someone that's never too far away from publishing a new article or popping up on BBC News. It's certainly a difficult act to follow from a trainee perspective, anyway.
I would agree with that. It's very true about his publication record, churning out papers all the time. Just like how we would write a shopping list, papers just come out of nowhere. And that makes me so jealous sometimes, James. I'll be very honest. But anyway, Chris, I think we are done with the accolades for now, aren't we?
That's probably enough, yeah.
I think so, yeah. So moving on to the real business of pediatric IBDology. So today's focus is all about the rising incidence of Crohn's disease and colitis. James, you have published extensively on pIBD incidence and prevalence, among various other things. Not forgetting your very impactful publications in other domains of pediatric gastroenterology. So I think the stage is all yours. The first question I would like to ask you is to tell us a bit about yourself, maybe starting with your academic journey in sunny Southampton.
It's very kind, and I'm not sure how I can top some of those accolades that you've given me previously, but maybe I'll try to keep a little bit more to the point and keep it concise. So yeah, I'm now an associate professor in pediatric gastroenterology. I also have a real interest in genomics and genomic medicine. But since I came to Southampton, having done medical school in Nottingham in 2012, I've been on a sort of academic pathway as part of my training, which is, I've been really fortunate to be part of this team, the Paediatric Gastroenterology team, for some time now, as both academic and as a clinical training. And during that time, I sort of followed this pathway where I've done a PhD, was a clinical lecturer, and now I'm this associate professor role and a pediatric gastroenterology consultant as well. But as you say, I've published various things along the way, one of which is, well, one of the interests we've had is looking at how disease incidence and more recently prevalence has progressed over time, both on the South Coast, but also a little bit wider now.
When you put it that way, it sounds like it's an easy pathway. I think we should all have got on it.
Well, I don't know. Sometimes you fall on these pathways and then they just take you along.
I think maybe you undersell yourself, but that's fine. That's part of the excellent character you are.
So, James, before you proceed to answer all the academic educational questions, would you like to tell us a bit about yourself, as in your family, your little boys?
Yeah, of course. So I've got two boys. They are aged 8 months and 3 years of age. I live over near Winchester, which is just north of Southampton. I was actually born in Winchester as well. Yeah, it's quite posh. But I haven't fallen far. Eventually, I'll come back home to where my family are from. I guess the other aspects of something that I'm very passionate about is the environment, and something that we quite often get mentioned is that I've given up flying. I'm vegetarian. I do everything I can to sort of aid sustainability. So I guess that's another big aspect of my personality that I think is quite important. And I'm going to use this as an opportunity to plug the fact that I think it's very important.
Oh yes, I forgot to touch on that. You don't fly, but you ski. You love skiing. Is there anywhere in Winchester that you can do some form of pretend skiing?
We don't get much snow down here. It's been sunny Southampton, not snowy Southampton, unfortunately.
Oh, that's true. That's true. Thank you for... Oh, yeah, one more thing. You don't need to tell me all the names, but I know your little boys have got fancy, charming, long names. Is that correct?
Yeah, there's absolutely nothing to do with me. They were all chosen by Catherine.
Probably fairly normal in Winchester as well.
Okay. Fair enough.
Oh, yeah, they're very short for Winchester now.
Right. Shall I get us back on track? I did mention that I wanted to get to know our guests, so I can't really complain too much about the chit chat. But James, before we begin and sort of ask our questions for the podcast, I guess it would be helpful for our listeners if you could just elaborate on some definitions of incidence and prevalence.
Yeah, of course. So incidence is the number of new cases you get within a certain population within a certain time period. So typically for incidence of disease, it would be per 100,000 of an at-risk population per year, although you could define it however you want with any number of patients that you wanted to look at and over any time period. And then prevalence is the number of patients that are existing with that condition within a set population. So similarly, you might express it as per 100,000, but you wouldn't give it a specific time period of which that covered. So it would just be the number of prevalent patients within that population.
Thank you, James. Now, reading all your published work, and of course, I must admit that I am a co-author in so many of your papers. Thank you for that. Your clear and consistent message has always been that the incidence of IBD has significantly increased over the last 2 or 3 decades. It was, I think, 1 decade when I was training as a registrar, but now it's certainly the 2nd or 3rd decade. Now, would you like to start from the work you did in Wessex and then beyond?
Yeah, of course. I guess it's very much not just my work. So this has been a sort of team effort over the last sort of 10, 11 years, certainly involving a number of different people. And as you say, you've been a collaborator on this, and Professor Beattie from Southampton has been very, very important in leading some of this work as well. But the first paper that we published from Southampton was back in 2014, where we looked at 2 different time periods from earlier on in the noughties and then straddling the sort of 2010 to 2012 period. And we saw that there was this 50% increase in incidence at that point within our local population. And we also then compared this to data from the British Paediatric Surveillance Unit survey, which was done in 98, 99. And over that time period, the incidence had almost doubled. So in that survey that had been done nationwide back in the late 90s in the UK, the incidence of inflammatory bowel disease was about 5 per 100,000 per year. And we saw that in our population, by the latter part of the cohort that we were looking at, which was up to about 2012, we were seeing rates of inflammatory bowel disease incidence and inflammatory bowel disease of about 9 per 100,000 per year. So not quite a doubling, but heading that way. And that sort of triggered us to look perpetually at our own cohort, which is quite well characterized and quite well defined in terms of geography at various time points since that. And we published updates intermittently right up until last year with some work led by Zach Green, who's one of our clinical fellows here, where we looked a bit more widely, not just at Wessex, but across the whole of the south and the south of Wales as well, to look at the increasing incidence over the last 10 years.
And from your knowledge of the subject, are those trends that you've seen in the south of England, is that consistent with other places, close by, like mainland Europe or even North America, which are sort of similar populations?
Yeah, so I think it's a really good question. And certainly what we've seen locally is being replicated in multiple different places, largely in sort of the developed world, I guess, for want of a better term. So the north of Europe, North America, Australia, New Zealand have all seen a sort of similar increase to what we have observed locally. And there's some really good sort of review publications that have come out, but there's one from 2022 that was looking at sort of a systematic analysis of the trends of incidence within pediatric IBD. And of those studies that they looked at, I think it was about 85% of them from across the entire world, not just across those countries and areas that I've mentioned, but across the entire world, demonstrated an increasing incidence of IBD within a childhood population. So it's very much not something limited to our own little patch in the south of England, but it's something that we've observed much more widely.
James, a quick question. Maybe I should have done research about this before hosting this podcast. It's about the pinpoint study. It's not published yet, as I understand. Is that correct?
I think there's an abstract that was published after a variety of different meetings, but no, I think it, and I'm not sure it looked at pinpoint incidence, so it didn't look at trends over time. But I think there is some data out there, but I don't think there's a manuscript on it yet.
Okay, so maybe once it's out, we'll have a separate episode on the pinpoint study. Now, coming to the trends of increasing prevalence and incidence, do you know much about what's happening in Asia and South America?
Yeah, so I think it's the first thing to say is that incidence of inflammatory bowel disease tends to be lower in areas of the world that are not North America, not Northern Europe, not Australia and New Zealand. So the countries in, this is a very broad sweeping statement, but countries in Asia and Africa tend to have and South America tend to have a lower baseline incidence of inflammatory bowel disease in children. But even within those populations, there also has been observed to be a similar increase, or there is an increasing incidence. Whether this is driven by changes in the sort of population, whether this is driven by other environmental changes, I don't know, and maybe that's something we'll come on to talk about later. But it's certainly from the data that's out there, and as I said, this review from Eric Benchimol's group in 2022 that looked at this very systematically, observed that increasing incidence was almost ubiquitous worldwide, not just limited to Northern Europe and North America.
That's very interesting. Coming to that point, now I trained in India, and I must say this was about X number of decades ago, but at that time, I never came across any child with a diagnosis of pIBD. Now, it may be that the resources were lacking, and that's why there were no diagnoses made. But I think, truly speaking, I didn't come across any case which seemed like IBD. But now I know from my colleagues back in India that there are cases, more and more cases, but of course I don't have the objective data to discuss right now on this panel. But thank you. That's very good and useful information.
I think there's probably a few things there that we can pick up on later. Certainly it's a big topic to go through all at once, but I guess, going back to the basics, reading through your reviews and others on the incidence of pediatric IBD, James, you've described gender in terms of incidence and prevalence, but you also go through disease phenotype, or the type of IBD that people have. Could you just share some insights on what that means and what the trends are?
Yeah, of course. So I think this is one area that pediatrics is a bit different to adult onset disease. So in children and young people, and by young people, for the purpose of this definition, is those aged less than 18, we would see higher incidence and prevalence of Crohn's disease, which is the opposite to what you see in adulthood, where you get a higher incidence of colitis. And we also see a higher incidence of disease in boys and young men, which again is the opposite to what is seen in adulthood, where you get more women with inflammatory bowel disease. So we do see some quite marked differences to adult onset disease. Now, in terms of trends and differences over time with regard to those phenotypes and incidence within those genders, we see an increase across the board, really. So if Crohn's disease has increased, colitis has increased, we see an increase in both boys and girls, but the differences between boys and girls and the differences in incidence between Crohn's and colitis have sort of remained steady over the years. So we're not observing one of the disease types or catching up with the other one. They're sort of being consistent. And I guess the other thing that might be of interest in that regard is the sort of slightly different ages that people can get disease within those groups. And I don't know whether that's something we want to come on to talk about later or something we could touch on now.
I think that would be a great idea. Go for it.
I think there's been a lot of interest in the age groups that are driving the increasing incidence of disease. And certainly when we've looked at this locally, we've seen that the most or the biggest increase in incidence as a proportion of the patients has been in that 12 to 17 age group, so a slightly older teenage age group. We also see an increase in a slightly younger group, that's 7 to 11, so those are the early onset inflammatory bowel disease. But what we haven't observed is any increase in the very early onset, so those age 6 and under. And that's sort of been consistent in a number of different studies, including some from across the UK and Europe. But notably, there have been some studies, especially those published from Canada, that have looked at the incidence in a very early onset age group, who've seen an increase. So there are some inconsistencies, although overall the trend is towards an increase in pediatrics, but it may be different subgroups of that pediatric population that are driving the overall increase in incidence that we're observing.
I was going to ask James, if it's okay, just leading on from that, I guess, observing the patients that we manage, it's easy to think that because there's more patients with IBD, there's more severe cases, but there does seem to be a lot of severe IBD around. Do you think that's just a phenomenon because of the sheer quantity of increased patient numbers, or is that in itself a new trend of worsening IBD?
I think it's a very difficult question to answer. I mean, it sounds like a bit of a cop-out, but I think I don't think we're seeing a milder phenotype. Maybe if we flip it on its head, I think that there isn't an increased accrual of patients with very mild disease that we don't need to treat in a relatively aggressive way. So I think from an incidence perspective, that would seem to suggest that we're not seeing, and this would be backed up by stuff like there's not really a change in the median age of diagnosis either during this age group, during pediatrics. But we're not really seeing, I guess we're not seeing what might be a criticism leveled at incidence within pediatrics, which would be we're just diagnosing adult onset disease earlier. But I don't think we're seeing a milder phenotype, and we're not seeing a creep in median age increasing over time. So I think we're seeing a true increase in disease onset during childhood. And I guess to come back to your original question about whether we're seeing a change in severity of disease, whether we're seeing more severe disease, I think that's something that the studies going forward probably need to focus on. But I think to flip it on its head, I don't think we're seeing an accrual of milder disease driving that incidence.
And I guess the challenge is, in the last 15, 20 years, we've introduced biologics, and how that has changed our overall patient cohort, and, earlier diagnosis, but earlier aggressive treatment then skews what you see, I suppose. Yeah,
definitely. And I think that the natural history of disease, I guess the entire purpose of some of these aggressive early biologic therapies and treating patients very aggressively, especially those with Crohn's disease, is to try and modify the natural history of disease. So we take away that long-term severity, or at least that's the potential that we have with these drugs. So I think we'll wait to see how that develops and whether we actually are modifying natural history, but it's definitely a possibility.
Very interesting. James, I think you've already explained this earlier, but overall, how do the trends observed in children align with the data in adult IBD patients?
Yeah, so again, I think it's a really interesting observation. We've spoken a little bit about some of the differences in the groups of patients that are more prevalent or have inflammatory bowel disease, a higher incidence and prevalence in childhood and adulthood, and how the boys are more common in childhood and women are more common in adulthood. But overall, there's sort of a stagnation of IBD incidence in adulthood. It doesn't seem to be increasing in the same way that it does in pediatrics. Having said that, although we are not seeing an increase in incidence in that adult age group, and there's been a number of studies published on that, including a big one from the Lothian area in Scotland, actually, because every child, we would hope, grows up to be an adult with inflammatory bowel disease. Every child with inflammatory bowel disease is an adult that grows up to have inflammatory bowel disease. Their prevalence is compounding over time. So actually, whilst we are probably diagnosing more and more patients, actually we transition them when they're 18 and they become an adult, and that becomes part of their adult prevalence. And so the estimates are that from various different studies that we're going to get to about a prevalence rate of about 1% of the UK population having inflammatory bowel disease by about 2030, 2035, which is quite a significant number of people. And similarly, data from the States would reflect that. So there's a study published quite recently in Gastroenterology where they were looking at prevalence of inflammatory bowel disease in various different insurance provider databases, and their incidence or their prevalence of inflammatory bowel disease was already about 0.7, 0.75. So that's about it's not too far off that 1% target that I was quoting for the UK. So everything seems to be increasing in terms of prevalence, but incidence does seem to have stagnated.
It's quite an interesting figure, that 1%. I think that really hits home and will for families as well. That's on the similar scale to celiac disease, which of course is, felt to be hugely prevalent by the general population. It's interesting to know what we're going to do about that sheer number of patients in our cohorts. I guess, the thing that you often hear from families when you get the diagnosis is, why did it happen? Is there anything I could have done to stop it? And we've touched on the fact that it is happening, and we don't at the moment understand necessarily why from the research. But from your understanding of that research, is there any idea or any sort of investigation that's going on as to why in particular IBD has started to increase or has been increasing so much?
It's a really, really important question, and it's a question I think we don't really know the answer to, if I'm honest. I think there's loads of things that we can look at in terms of correlations. So certainly coming back to a point we were talking about previously about increasing incidence in places that historically have had very low incidence of inflammatory bowel disease, so places in Asia, South America, where potentially a westernization of diet has occurred over a similar time period. Similarly, in the UK, I guess there's much more in the way of processed foods, things like this, but I think we're far, far away from being able to pin the cause on that. The data is not there to suggest that is the cause. It's just something that seems to have increased in prevalence at the same time as inflammatory bowel disease has become more common. So I think that's something to think about. One thing that we can point to is that, and this is another area of interest for me, is the genetics of inflammatory bowel disease. So we've got lots and lots of genes which are risk factors for getting inflammatory bowel disease, but the increasing incidence over the last 20, 25 years during childhood is far, far too quick for that to be a genetic change. Those changes take thousands and thousands of years. So this isn't a change in the sort of genetic structure of the population. It's far, far too rapid a change for that. So it must be something environmental driving it on the background of that genetic risk that's probably always been present in the population.
James, I'm sure we will have lots more episodes on the various OMs in pIBD. I'm sure you'll love that.
I would love that.
We would love to have you back for many of these episodes, all lined up in succession. Chris, do you need any more enlightenment on the incidence prevalence before we move on to the literary part of the podcast?
The fiesta resistance. No, I don't think so. I think James is, as you know, such an interesting person that has, such a depth of knowledge about IBD that it's very tempting to keep asking lots and lots of questions. I think we'll save it for other episodes and keep the listeners sort of on tenterhooks, waiting to find out more.
Yes, and I would resist the temptation to ask any more questions because, James, your royal elephant is waiting outside the office to take you back home. So
it's an electric car, by the way.
Thank you.
Fantastic news.
Yeah. So without much ado, I will go on to recite my poem. Yeah?
Oh, sensational. That's also great.
So my disclaimer for the poem is that the research community should take no offense to the first verse of the poem. It's only a poem.
I'll wait for this, Tracy.
It's not targeting anyone anyway. So the title of the poem, IBD on the Rise. In research, stats that seem not to lie may sometimes do so if the unwise obliging acolytes piece together a wishful score of botched up numbers that will only prop tilted versions of science to the fore. In IBD though, numbers are truly on the rise. Is it the unnatural foods or their additive blends in clever disguise? Or some other clean hypothesis, yet unknown to the researching wise? Thank you. That's the one.
Wow. If a clap would come through on the mic, then I'd clap. I'll give it a go. Thank you, Tracy. I think that gives away that you already knew James's answer as well. You've already alluded to the unnatural foods.
Well, I've worked with James.
Disguise, so
yes,
maybe we should be interviewing you here. If that's everything you wanted to say in your poem, Tracy, I think we'll thank the listeners. I'm assured that Dr. Coelho's poems going forward will not be generated using ChatGPT or any other AI platforms otherwise. I think probably we're just in the presence of a true creative genius. What do you think, James?
Absolutely, no doubt about it.
Oh, thank you. I'm very humbled. Very humbled. Thank you.
I think he's wasted in gastroenterology.
Yeah, sensational.
And the confidence to do it, I think, is more than impressive. Right, on that note, Dr. Ashton, James, absolute pleasure chatting to you. I think, genuinely, this is not with any sarcasm. You do have a wealth of knowledge on the subject. And I think that, just touching on that incidence and prevalence is really interesting. And I think that there's a lot more that we'll talk to you about in the future.
Pleasure.
So thank you very much for joining us.
Thanks very much.
We'll look forward to seeing you again.
Dear listeners, thank you for joining us on this very first episode of the series. There will be many more to come, so keep your ear to the ground. So signing off, goodbye for now. Thank you.